So this actually was the pre-apoptotic moment. And I think it's unbelievable. Now, when we do, why Avastin was creating this damage? And I have to say that if you look at all the myopic eyes, also without CMD, and you take a late frame ICG, the ICG is always showing an area bigger, suffering area bigger but not RP. It seems that the disease is more in the choriocapillary and then on the RP cells. If you do the opposite if you do the same in Stargardt disease, you see the opposite. You see that the choriocapillae follow the changes in the RPE as I showed before. So, but it takes years. You can see after 10 years an increase of lesions that we saw in a few months in this patient that had anti-VEGF therapy. Now, why can happen with anti-VEGF? Anti-VEGF, the pan-anti-VEGF, Lucentis and Avastin, are acting in a different way compared with macrogen. And in fact, the effect of the very active lesion is completely different. I can show you in a dynamic angiography that the real effect is the decreasing of the size of the vessel. And the shrinking of the vessel is related to the fact that VEGF is producing nitric oxide. And you know the nitric oxide is the most powerful vasodilator of the body. You know, nitroglycerin for the angiosperm, it's nitric oxide. Viagra, it's nitric oxide. So it's a vasodilator. Now, if we have an antagonist of vasodilator, we actually have a shrinking of the vessels. And here, in an already suffering area, if we close the vessel even more, we are suffering RPE cells, so atrophy. So right now, after seeing this patient, when we have to decide to do photodynamic therapy or Avastin in the patient, at least we suggest to the patient that can have some atrophic changes due to the drug if we use an anti-VEGF, because we can in some way predict that, at least in a short time. And I think it's it's safe to say to the patient that we can really close the lesion, but because of that we started a multicenter study using macrogen instead of Avastin for a myopic lesion. I don't know if it's acting the same way, because in the active lesion is not acting on the permeability of the vessel or the stimulus of the growing of the vessel, but more on the nitric oxide depletion that we have the closure of the vessel. So we will see, but it's quite an interesting situation. I want to show you another interesting case that I learned from the OCT, and it's completely different from what we expect or we learn in let's see. Yes, let's see. Okay, so these are the optic nerve head drusen, no problem. With the OCT spectral domain, you see, are very well delineated. In autofluorescent, you know that it's a normal autofluorescent. This is not lipofuscin, it's glial tissue. But the goal the topic of this presentation in this case is the angiostrix. What are angiostrix? Everybody knows that angiostrix are breaks in Brooks membrane. And I will show you something. Just to give the reference. These are the vessels here. Sorry. These are that Brooks membrane, and you see a rupture in the Brooks membrane, the angiostrix, a rupture in Brooks membrane. And here it's an angiostrix, but the Brooks membrane is completely normal. And what changed in the photoreceptors? So what we say is based on the gold standard. What is the gold standard? Histology. Now, I will show the paper that was published in 1977 and where everything is based on. This was the paper. And we are describing this area, but we were not taking care of this because it was impossible to correlate the angiostrix with, specifically with the fundus picture and the histology. And so they describe Brooks membrane rupture here, some changes here, but look, they didn't look up and they didn't see the photoreceptors that are here, there. So probably the first step of angiostrix is changing in the photoreceptor level. And eventually you will have some degradation and Brooks membrane rupture, but not at the beginning. And sometimes it's dangerous to say histology is the gold standard because you have also to correlate exactly what you see in the fundus with what you get from the histology. Okay, yes, this just to show what happens with laser. I will show you another correlation with a laser treatment, early treatment, what happens immediately after the treatment, and some months later. And this is a nice paper done by John Marshall with the effect of the laser. And here what we get from the spectrodominosity. It's quite similar to from what we saw in the histology. So we will do a live histology, and probably we will change our mind many times. What I tried to show you, but I couldn't find the image here, was that the increased fluorescence that was described as a CRPE is just a lack of tissue, and the increased autofluorescence just because there is less, a blocking tissue for the autofluorescence that comes from the RPE cells, and that was possible just in that way. Another situation is the autofluorescent image and the central serous choroid retinopathy. And also in that case, you cannot do an histology keeping the fluid because just you cut the eye and the fluid is gone. Here you can actually do live histology and keeping all the components of the disease. That is quite interesting. So we will change many ideas with this technique. Combining images, what we see, and what we can actually take with a spectral dominosity. Any other?
Él hace indocianinografías en prácticamente todos los pacientes. La indocianina Y
Los miopes sobre todo.
sí, no, prácticamente excepto diabéticos, donde el escáner se hacen todos indocianismo, porque me da una cantidad de datos que no se ven con que ustedes hacen indocianinografía de all patients.
Yes. Well, except for diabetes, if, as you said, but sometimes you have some information also in diabetic patient. We don't do routinely, but sometimes and we don't understand why. There is some macroaneurysm that are very well evident with ICG and not with fluorescein and vice versa. We don't know why, but sometimes.
Además, el año pasado Guillermo presentó en un país de esto, ustedes se acuerdan, que yo en ese caso había dicho un estudio con métodos no invasivos o para pacientes que te dicen que tienen alergia o para niños, entre la autofluorescencia y el infrarred y el OCT se pueden llegar a una cantidad de diagnósticos que realmente son espectaculares. Y con este otro tipo de modelo de OCT. Okay.
Thank you.
Gracias.
Really very, very, very nice your
Thank you.
knowledge.
Thanks.
You are very impressive.
I had to do autofluorescence because particularly the clinical use is not fine. You cannot find in any book or because I was part of a book that was published by Frank Holtz and Alan Bird, but that book was mostly basic idea and research purpose, but not clinical use. So when you have to deal, in clinical practice with some information that you can get from your first. Yes, there is a book from. Yes, it's published by Springer and Bell, I think. The idea is that to have at the end of each chapter a table where you have all the information that you can get for all the type of imaging and giving the information is common, uncommon, not visible in that disease. You can have an idea and a thinking way of doing a diagnosis just based, you see an image, it's you have in autofluorescence you have higher autofluorescence and then you have infrared highly reflective. So at the end you can say, well, yes, this is typical of this type of lesion. And I think it's a lot of work, but at the end I think it will be useful for thinking in a different way, comparing with what we are used to deciding based on only a fluorescent, red-free and color picture. Other information, but not what I told you about, but it's based on many years of autofluorescent work. But I hope in less than 1 year the book will be published. So you will have the possibility for one.
El libro este que salió no tiene nada de OCT, todo esto de ahora, porque esto se que muestra, dice que está junto con la angiografía. Entonces, ese libro no tiene prácticamente imágenes de OCT. Todo esto que se va desarrollando en un año. OCT 1 year, okay?
No, that one was yes, just 1 year. In January, we had the first prototype in January 2007. This type of OCT.
Are we authorized to to translate what you have said today and to publish in the magazine of the Cathedral?
Yes, but please do not show the images because the images are under
We
publication.
can modify not to show the images and sending to you to correct, to
Okay,
say,
okay, okay,
and so you say we can publish it,
yes,
okay?
okay,
But we find it very interesting.
thank you very much.
I have a question. The last part, you show two different, the first time with the 48 nanometers and the other one. What is the difference? Why you choose one or the other? Or it is
You should do both
both?
because it gives different
Different
information
information.
and is not disturbing the patient. I didn't say almost anything about infrared, but I can tell you that I can give you the same lecture just using infrared.
Okay, so
And
you can have the same information.
yes, well, other information.
Other information.
You
Complementary.
exactly, and depending on if one gives one information combined with the other, you can do a diagnosis much better than not most of the time of the normal jaws. So, and please try to do dynamic angiography because it's so important. And one of the things that I think is crucial is that once you learn something and you want to go back and see, for example, early frames of the angiography, and you have a movie, it's like doing in that moment again the angiography, but you did 10 years before. If you don't do such a thing, all the information are lost, and it's easy to do a movie, and it doesn't take any particular skill. Just press a button, and if you are able to take a still frame image, you are able to take a movie. That's it. But it's really important.
With the HRF2, the autofluorescence is with 400.
If you use for fluorescing, it's 488, so it's the blue one. If you use the ICG filter, it's the near infrared, and it's the yellow one. It's the 790. So we actually did today some example of Ocular and so on.
Oh, thank you very much.
Thank you.
Thank you very much.